Yeah. Hi, a warm good evening and welcome to all the faculty, seniors, and dear delegates. We welcome you at yet another important and brainstorming session of Journal Club, which is organized by ICOG and Jogi. Now, in the presence of all the senior faculty members and office bearers from FOXY and ICOG, with conveners, respected Dr. Sujata Darvi Madam and Dr. Radhika Madam, I would like to introduce today's coordinator for the program, Dr. Prabna Changede Madam. So let us go ahead with the program. I would like to share my screen. Okay. So Dr. Prabna Changede Madam, currently senior obstetrician and gynecologist, currently working as associate professor at Sion Hospital, Lokmanya Tilak Medical College. She is currently secretary and manager at Journal of Obstetrics and Gynecology of India, and now she has become second joint assistant editor, which is
Thank you so much, Sunil. Thank you.
yeah. Madam, kindly
Hello,
go ahead
everyone.
with-
Hello, everyone. I will be introducing a master of ceremony for this program, Dr. Sunil Tambekar. So, Sunil is an assistant professor at Vadia Maternity Hospital. He's a laparoscopic surgeon and he is assistant secretary and manager of Jogi with
Thank
many
you.
publications and awards to his credit. I
Thank
request
you.
Sunil to introduce both our conveners for today's program, Dr. A.G. Radhika and Dr. Sujata Darvi ma'am.
Yes. Thank you, madam. Dr. A.G. Radhika, madam, she is senior obstetrician and gynecologist, a faculty at University College of Medical Sciences and Guru Tegh Bahadur Hospital, New Delhi. She is really important to us as far as Jogi is concerned because she is a torchbearer in taking interest in research and
I
having
think,
advanced
Sunil,
research
excuse
methodology
me.
activity. Ma'am, briefly, I'll introduce you. She is
Yeah.
National Coordinator for Clinical Research, FOXY, 2017 to 2022. Currently, she is working as a National Corresponding Editor. Then she is LMIC representative for Guidelines International Network. It has been privilege for us as far as India is concerned because she's expert reviewer at Cochrane Collaboration, Jogi, IJMR, and JSFOG, and she's a recipient of many awards. Thank you, madam. Thank you for joining. Dr. Sujata Darvi, madam. She is currently editor-in-chief at Journal of Obstetrician and Gynecology of India. She is a senior consultant obstetrics and gynecology at various hospitals in Mumbai, including Nauroji Wadia Maternity Hospital, where she and Jagjeevan Ram Hospital, where she is as an honorary. She is past secretary and treasurer MOGS, past president Mumbai Menopause Society, and secretary MOGS. And she's a recipient of many awards. Thank you. We welcome you, ma'am.
Yeah. Thank you so much. So, Radhika, I start. Okay. Thank you, Sunil, for a kind introduction. At an outset, I would like to welcome one and all for this Foxy ICOG Jogi Research Methodology and Journal Club program, which we hold it once in a month. And for that, I would like to express my gratitude to Foxy President Dr. Sunita Tandurkar, ICOG Chair Dr. Parag Binewale, ICOG Chair-elect Dr. Sheila Mane, ICOG Vice Chair Dr. Ashok Kumar, ICOG Secretary Dr. Sarita Bhalarav, and of course Foxy Secretary General Dr. Suvarna Khadilkar for giving us an opportunity to have this program along with an ICOG. I would also like to express my gratitude and of course constant support for my co-coordinator Dr. A.G. Radhika, and also my gratitude to our coordinator Dr. Pradnya Changade and Dr. Sunil for being an MOC for today's program. I would like to request Dr. Radhika to give a little bit of an overview of today's program. Over to Dr. Radhika.
Thank you very much, Dr. Sujata, and warm welcome to everybody and a very warm good evening too. So, we have been trying to address various aspects of clinical research. So, today it turns out to be something on qualitative research. I think in our country, we have been traditionally focusing for many years on mortality, with the fall in the mortality statistics and the increase in the lifespan and the morbidity of coming out of a high risk scenario, it is so very important for us today to talk about the quality of life aspects and what happens to those women who got saved. So it is today, the focus of today's journal presentations is largely going to be on qualitative studies, how to address them, how to approach them, and how to basically work out a strategy to conduct such a research. That is number one. And then the live demo is on RedCap, which is basically a software for registering and recording data from large clinical research. Confidentiality and collaboration, as well as working on the data in from multiple sites, because multi-site clinical research is what is the most important aspect of work today. So RedCap is going to be focusing on that. So we promise you it's going to be a very important informative session. So over to you back again, Sunil, to please carry on with the program for the day.
Dr. Sunil, please.
Yeah, I would like to
Sunil,
quickly.
please introduce the office bearers of Foxy once.
Yes.
Nilima, please play the slide of Dr. Sunita Tandulwadkar, ma'am. Please change the slide.
Sunil, in the meantime, can start
Yeah,
reading.
yeah. Is the screen visible?
Yes.
Yeah, you start. You start,
Yeah, yeah.
You
Sunil.
start introducing.
Dr. Sunita Tandurkar, madam, currently she is President Foxy. She is a leader for all of us, under which these two academic wings of Foxy, we are conducting such important programs, Jogi as well as ICOG. Madam is President-elect ISAR. She is founder President of Society of Ovarian Rejuvenation from 2023. She has been past President of POGS Pune Society, Chairperson, Founder, Honorary Secretary of ISAR MSR. She has been past president of IAG 2019 to 2020. She is a recipient of many awards and she is being a guide for us. Madam has sent her apologies because she is busy with another Foxy program right now. But we welcome you, ma'am, and thanks for the guidance. We welcome Dr. Parag Biniwale, sir. Sir is currently chairperson ICOG 2025. He is senior consultant obstetrics and gynecology
Thank
from
you.
Pune.
No, don't waste time in reading.
Yes, we welcome you, sir.
It's okay.
We welcome you.
Thank
Thanks a
you.
lot for your guidance. Dr.
Good
Suvarna
evening. I bring
Kadekar,
greetings
madam.
from Theology, and it's indeed,
I think you let Dr.
it's indeed a
Parag speak first.
yes. Nilima, stop sharing screen, please. Yeah. Good evening. I bring greetings from ICOG, and it's indeed a great pleasure to address the meeting today. This is the joint activity of ICOG and Jogi on research methodology and journal club. At the outset, let me compliment the editor-in-chief of Jogi, Dr. Sujata, for tying up with ICOG, and of course our own Dr. H. Radhika, the governing council. Sujata, I must appreciate the enthusiasm of the editorial team, Prajna, Sunil, and everyone who are so enthusiastic when we start planning this program. Thank you very much, guys, for being here with us. Special thank you to our experts today, Dr. Saswati Sanyal Chaudhary, Dr. Meena Samant, and Dr. Shobha Gudi. And of course, I'm definitely looking forward to the presenters, Dr. Ayesha and Mugdha, who are going to present some interesting data, and I'm sure it's going to be a great learning experience. So let's go ahead with the program. Happy learning to everyone, and thank you very much.
Thank you, sir.
Thank you. Thank you, sir. Quickly, I would like to introduce Dr. Suvarna Kadekar, madam. Madam is currently Secretary General of Foxy. She is a senior obstetrician and gynecologist and Foxy leader. Currently, she has been just finished one dynamic and active year as a president of MOGS. We welcome you, ma'am. We are looking forward for your guidance. Dr. Ashok Kumar, sir, is currently a vice chairperson, ICOG 2025. He is from Delhi and senior obstetrician and gynecologist, and he contributed to Jogi importantly. Dr. Sarita Balera, madam, she is currently secretary ICOG. She is senior consultant obstetrician and gynecologist from various hospitals in Mumbai. Thank you, ma'am.
Nothing, no.
Ma'am, kindly guide us with few words, ma'am. Thank you.
Thank you very much, Dr. Sunil. I think Dr. Parag has said everything from the ICOG side, so I will not delay further, and I look forward to a very, very interesting evening. Thank you.
Thank you, ma'am. Thank you. Let us go ahead with the presentations. So hereby, I would like to introduce our speakers of the topics as well as the experts who will be joining as a chairperson. Dr. Shobha and Goody, madam, it's my proud privilege to introduce madam for yet another important session, and I am fond to introduce her. She being my teacher, my postgraduate teacher from Bangalore. She heads the Department of Obstetrics and Gynecology at St. Philomena's Hospital, Bangalore. She's been past president, Bangalore Society of OBGYN 2018, chairperson, Family Welfare Committee, FOXIT 19 to 21, secretary, Bangalore Menopause Society, and assessor at various panels and boards, active FOXI and ICOG leader.
Thank you.
We welcome you,
Thank you.
ma'am.
Thank you, Sunil. Thanks a lot.
Thank
Thanks.
you. Professor Saswati Sanyal, madam, senior obstetrician and gynecologist, professor at Guwahati Medical College, chairperson, Medical Education Committee, 2013 to 15, vice president, ISOPAR, 20 to 22, chairperson, Eni Isa, and past president, Guwahati Society. Thanks a lot for joining, madam. Thank you. Dr. Meena Samant, madam. She is senior obstetrician and gynecologist. She is heading the department at Kurji Holy Family Hospital, Patna. President, Patna OBGYN Society, 23 to 25. General Committee members of ICOG, Foxy Clinical Research Committee Chairperson, and senior leader in Foxy as well as ICOG, having many publications and awards. We welcome you, ma'am, for joining the session.
Thank you so much. It's a
Yes,
pleasure.
ma'am. So let us go ahead. I would like to request one of the chairperson to introduce the speaker. The first speaker is Dr. Aisha Ahmed.
Okay, can I go ahead? Dr. Saswati here. Dr.
Yeah.
Aisha Ahmed is the professor of obstetrics and gynae, Career Institute of Medical Science and Hospital, Lucknow. She is the founder member and joint secretary, Stillbirth Society of India. Great. Editor, SBSI e-newsletter. Co-editor, Pan Asian Journal of Obstetrics and Gynecology. And her areas of interest are obstetric Doppler, ultrasound, fetal growth restriction, critical care obstetrics, and decreasing preventable stillbirth. Thank you.
Dr. Aisha, you can share your screen.
Okay. Okay. Am I audible?
Yes, yes.
Yes, you are.
Good evening, esteemed colleagues, and thank you very much for giving me an opportunity to present my work. So I'm going to present this paper. It was published in South Asian Journal of CEPHOG. So, improving uptake of healthcare facilities in obstetrics and gynecology at a rural health center in Uttar Pradesh, a quality improvement initiative. This was the publication. Now, at the outset, let me give you some background information. I stay in Uttar Pradesh, and in Uttar Pradesh, 77.73% of our population lives in rural areas. And there's a huge disparity between availability and accessibility of healthcare services in urban and rural areas. While our major challenge remains strengthening our primary healthcare system, we have gone ahead, we have achieved a lot in this. We've improved the infrastructure and manpower at primary health center and CHC level. Now, let me quote this study, a very interesting study by Das et al. And they said that 74%, so they sampled several villages all across India, and they found that 74% of the sample villages had at least one healthcare provider. However, the quality of care varied among the low and the better performing states. And unfortunately, the average provider knowledge in Uttar Pradesh is below 2 standard deviations of the best performing states like Kerala. So, with this background in mind, we thought if we give better healthcare providers in rural areas, so will the healthcare improve? And that was our idea. We thought that yes, there are less healthcare providers, and less trained healthcare providers. So let's give them a better healthcare provider and a better infrastructure. So, as part of NMC guidelines, every medical college has to have an associated rural center, an urban center. So, this was a rural center. The building is built in 18,000 square feet. There are 22 spacious rooms, 8 OPD clinics, and it caters to neighboring 21 villages, a population of around 40,000. So as you can see over here, this is the entrance to the building. It has a nice view and a very clean reception and OPD rooms. The OPD clinic we ran from 9 a.m. to 2 p.m. with no consultation charges and subsidized basic laboratory charges. And we had a GP, we had obs and gynae residents and medical interns. We were giving primary healthcare treatment to the patients and free medications for 3 days. What we found that despite giving all these facilities, the daily attendance rate remained stagnant at 66 patients per day. We were not able to improve the attendance, whatever we were doing. So, using the PICO construct, we formed a research question: what will improve the uptake of healthcare facilities in the rural community of Lucknow district? And with this research question, our aim statement was to increase the uptake of healthcare services in the OPD clinic of our rural center by 25% over 3 months. So this was taken as a quality improvement initiative. We started with the formation of a team, a QI team, which consisted of personnel from the hospital administration, 2 consultants from obs and gynae, the in charge of the rural health center, deputy nursing superintendent. And then we came together, did a couple of meetings, did a lot of brainstorming. And finally, we did a root cause analysis. So this is a method to analyze the reasons behind a particular problem. There are different ways in which we can do a root cause analysis. And we did a fishbone analysis. So in a fishbone analysis, we sit together and we think of this is the present situation, low uptake of healthcare facilities at rural center. So what are the policy measures? What are the personnel involved? Lacking. What are the problems with the procedure and what are the problems with the place? Using this fishbone analysis, we found that first of all, there was no policy for any dissemination of information. There was no policy for data collection. While we were providing basic facilities, we were also giving some obs and gynae residents. However, there was lack of specialist availability for common specialities. So there was no consultant from obs and gynae who was going. There was no consultant from pediatrics, from medicine who was going. And in procedures, there was no ultrasound facility available. Because of this, the patients, they thought that, when I'm going to get an ultrasound, I'm going to come to Lucknow for the ultrasound. So why not consult over there only? Why do I waste my time consulting over here? Then go ahead and get an ultrasound done in Lucknow and then come back over here. So loss of wages was an important consideration for these people in villages. And then there was no place for emergency labors, DNC or DNCs, common procedures in obs and gynae. This is how we do a QI initiative. So initially we've done a brainstorming. Initially we formed a team, identified the members who will be taking ahead that initiative. Then we do some brainstorming. And finally, we identify the challenges. So using the fishbone analysis, we identified these challenges. After this, we designed our study. So the important thing is to, make our aim very clear. So the aim was to increase the OPD attendance by 25% over a period of 3 months from the existing baseline of 66 per day. And important part of QI initiatives are to outline at the outset what will be the indicator of your success, what will be the indicator of your process, and what will be the indicator of your outcome. So our success indicator was achieving an OPD attendance of at least 83 patients. So rise in 25% over 66 would be 83 patients. The process indicator would be how many patients are attending the clinic every day. And the outcome was percentage of rise in the OPD attendance. Then another important thing which is in the methodology, is how are we going to collect the data. So we had daily data collection by the resident doctor, how many patients are coming, how many old patients are coming, how many new patients are coming. And then every day, this data was evaluated by the designated QI member. After this, weekly analysis of data was done. So sometimes we used to have on-site meetings, and most of the time it would be Zoom meetings. And monitoring was done by there was a weekly meeting of the QI team for the data update, and then we had a time series chart at the end of every month. So we had 3 months to perform this study. We'll be coming to what this time series chart is. Any QI initiative is broken down into small bits and pieces by this methodology, which is PDSA, plan, do, study, and act. So you plan something, you ask yourself the questions, whom to consult, what to do, where to do, why to do, how to do. Then you actually do that thing. Try implementing the small change. And all these changes in a QI initiative are broken down into small implementations. Then you study. After implementing, you study what is the outcome, whether you've been able to achieve what you wanted to achieve, and then you again refine your ideas, and then you plan the next PDSA cycle. So we wanted to increase the OPD attendance. We broke down this into different PDSA cycles. So the first PDSA cycle was, after having identified the challenges. So the first PDSA cycle was to ensure availability of specialist care and appropriate data collection. How did we go ahead and do this? First of all, a decision making was done by the hospital management. All the department heads were sensitized. So this is something which we need to do. This is something which we need to do, which we have to do. And finally, we had an office order by the principal that all the specialists will be posted at the RHTC by a rotation basis. What did we adopt? Posting of residents from all clinical specialities as well as specialists. So specialists, they would be overseeing that these residents were going, and they would be going for a visit to the RHTC also. The learning that we had after this PDSA cycle was that it's very important that everyone in the team is sensitized before. It is very important that we have an official directive for compliance with a new strategy. So whenever you're going to bring out something new, we had an official directive from the principal that made things easy. We did do a prior sensitization, by calling all the departmental heads, but till the time we had an office order, things were not working. And that data collection needs to be robust. The next PDSA cycle was run from 11th to 30th September. And we saw that the OPD attendance was 91.85. And the change idea was to ensure birth preparedness for emergency labors. So we decided to upgrade labor room. We had auditing of the instruments and machines, list of requirements was prepared. The team was sensitized. How are we going to conduct delivery, and how are we going to transfer the cases in case of emergency to a tertiary center? And the ambulance facilities were rechecked. What were the measures that we adopted? That ambulance facilities were confirmed and labor room was prepared for emergencies. Again, learning points that, just the presence of facilities does not ensure that you are ready, you're functional, you need to have regular audits. Then next change idea that we saw that we had was, we saw that the OPD attendance had become 99, and then again it was 87.2. Again, it had decreased. And some of the reasons that we found was because there was no availability of ultrasound. Again, so we took some decisions to place some residents and consultants from the radiology department, sensitizing the radiology team. And we did have a machine, but we didn't have residents before. So our learning was that mere presence of machines does not ensure that a facility is available. You need more skilled operators. And then finally, we had the fourth PDSA cycle wherein we were disseminating information about the availability of services. So we had IEC brochures prepared in local language, which were validated, sensitized the community healthcare workers, and then we conducted regular camps displayed these posters and brochures in different villages, surrounding villages. And the learning that we had was that we really need reiteration in the form of IEC posters and brochures whenever we are going ahead with any quality improvement initiative, and involvement of local people from community is beneficial. Then we come to what were the balancing measures when we were conducting the study. So balancing measures are whenever you're going ahead with some initiative, there are some negative things that are going to come out of it. So how are you going to balance, maintain a balance, and how are you going to counter those negative things? For instance, in our study, because the residents we sensitized the department, and then we posted the residents at the center. So now, because of this, the work pressure increased on the main team at the medical college. There was resistance. They were not willing to place the residents. Also, there was an initial hesitation because the residents used to feel, the postgraduates, that we have a lot of workload over here in the medical college. At the rural center, there's no workload. So our learning will suffer. To counter this, we conducted sensitization of residents and consultants. We welcomed dialogue, and then we, reiterated that everyone would be posted one by one. It isn't as if the pressure is coming on one person only. And gradually, we saw as the clinical work in radiology increased, we saw that there was an increased compliance among the radiology team. So balancing measures are a very important part of any QI initiative, because whenever you are going ahead and doing something, you're going to face a lot of resistance from even well-meaning people. Now, this is something which is known as a process flow chart, which is integral to a QI initiative and to publication of the paper. This is what we did. And so the previously it was patient was reporting to RHTC. He was examined by a GP, given medicines free of cost, and then advised to consult at the tertiary college in case of any specialist care requirement. So what we did over here was we referred to the specialists who were posted at the RHTC, and this cycle, it broke over here. So the patients now, they didn't have to go to the medical college, and they were provided with specialist care over here. And because it was one by one, all the specialists were posted, so it wasn't as if like someone was being penalized. And then we also gave compensatory off to those specialists who were doing duty over here. So they would also be compensated for doing some extra work. Then previously, we would advise the patients to consult at the tertiary hospital in case of requirement of any ultrasound. And when they would be going from the villages to the main city, to the medical college, on the way, there would be so many small centers mushrooming with ultrasound clinics, and a lot of them. Am I audible? Am I audible?
Yes, you are audible, madam. Please go ahead.
Oh, okay.
Yes.
So we made ultrasound facilities available for them. Again, this nexus between the different centers, especially with they were with wrong reporting. So, we broke this nexus. And then patients, yeah, previously we were encouraging them to follow up for healthcare. Now we were training nurses, residents, disseminating information to surrounding villages, and we designated 2 days as scam days. So, just to add kind of glamour. This is the present infrastructure layout at RHTC. This is our ambulance. So in this ambulance, we can perform cesarean sections also, patient resuscitation also. We place this ambulance at the center just in case of we need it for any emergencies. This is the ultrasound room. We have that machine. And this is the OPD clinic, pathology, and this is some very basic IPD for the patient. And this is something which is known as a time series chart. So we can see that over a period of time, the number of daily patients increased. After the first PDSA cycle, we had 76 patients, then 91, dropped to 87.2, after which we gave ultrasound facilities, and then again picked up with all these, the brochures, IEC brochures that we were disseminating. And finally, we came to a stage of sustainability. So please remember that when we enter sustainability, that is when our initiative has actually, entered a phase of a plateau. Now, the national data, says that there's deficiency of almost 80% specialists.
Sorry to interrupt you, ma'am.
Yes.
Your time is up.
Okay. Can I just the last slide? So the lessons learned were we need to understand what care seekers want from us, inform them about the availability of services, make the process of referral transparent and need-based, and we need to have systems in place for robust feedback. Thank you very much.
Thank you, Dr. Aisha. I think that's a really, really very, very interesting study that you have done, because nowadays qualitative study is not being done so much, and you have made it so beautiful, and how this really worked in your center. A lot of people, I think they do this kind of work. It's not that they are not doing, but they don't know how to put it in words. Then how to, the way you have put it, how to analyze is the fishbone. So everybody should learn that how the quality research should be done. Congratulations.
Thank you, ma'am.
Any other comment from other things?
Not only the design of the study, but the study itself, it's so relevant because sometimes these health centers, they are made, but the full utility is not there to understand how best it can be used. I think that was a very relevant subject also you have. But I was always thinking, putting a specialist in rural setup, does it really work? Is it sustainable? Those kind of things also comes to my mind. Because
Yes.
basic health system is something we all need, and something for the other things one can always refer to a higher center.
Ma'am, just because it was part of our, like NMC has made it mandatory for all the private colleges to have our the rural center.
Right.
Because it was under
Correct.
could post the specialist over there, and then we also gave them half compensatory of for going over there, so they were also sort of compensated.
Yeah, so
Really.
correct. So hello,
Yeah, madam.
am
you
I
are
audible?
Yes, madam, you are audible.
Yeah, just for wonderful work. And I think how long has this been in place? An year
Ma'am,
or 2 years or longer?
ma'am, we did in 2023, end of 23. So it's been 24 and 1.5 years that we've entered the sustainability phase.
So have you published your work? Have you published it yet?
Yes, ma'am. Just recently in FOG.
Acha. Oh, yeah, that is why you have featured today, right? Obviously, it's a published article. That's why you're here. That congratulations for that. What I wanted to know is going forward, you can have more outcome variables, like how sustainable it is and what are the challenges you encounter in keeping it going in terms of in terms of training for this kind of service in terms of availability of material, because you said you are solving a lot of transfer problems. You are able to transfer women early because of this, right?
Yes, ma'am.
So the delays which are going towards maternal death and morbidity, you're trying to solve. So if you could relate your future research in that direction, and if
Yes.
you can make your work more robust, it will be great. So thank you very much for that presentation, and wish you all the best for future. Thank you.
Okay, any questions from the delegates and senior faculty members as well as seniors from Foxy and ICOG have joined the program. We welcome Dr. Vidya Tobe, madam.
Sunil, may I make a comment, please?
Yes, ma'am, please go ahead.
So I think it was a very wonderful, it was a good presentation and very lucid and well done. And the most important take home message, I think that people need to be familiar with the PDSA cycle. So it is it gives a perspective, seemingly difficult, challenging problems which what we read in the books is not what you are able to practice. So, what seems to be a humongous problem when you break it down into pieces, identify the bottlenecks, and be able to rectify them and put it into an audit cycle, I think is extremely important. And I must congratulate you, Aisha, for this great presentation. And also to the younger audience, that today the world has changed. So we must stay updated with these processes, and don't think this is out of the ordinary. This is now almost the norm of the time. So thank you very much.
Yes, madam. So this gives message to postgraduates that qualitative studies are important and it is not difficult. With the help of seniors, you should go ahead with such. And in today's era, data is going to speak for itself. So Dr. Aisha, we congratulate you because this is going to propose to the government how the healthcare providers and specialists are required in rural area. And as Dr. Goody madam said, this can further culminate into clinical outcomes, the better clinical outcomes you have provided. So we once again congratulate you on your study. Thank you very much. Dr. Vidya madam, Toby madam has congratulated you on your excellent presentation. So if any doubts, please go ahead or put in the messages and conveners can take ahead the program.
Yeah. Hello.
So let us go ahead with the next presenter. Saswati madam, you are going to introduce Ms. Mugdha.
I think Dr. Somebody else can introduce. I have already introduced the first one. Meena, Dr. Meena, can you? Dr. Meena. Okay,
Okay.
I can go ahead because if they are not
My
there.
network is a little
Yeah.
tricky, so Saraswati Di, better you go ahead.
Okay. Thank you so much. So Dr. Mugdha Barik is a biotechnology specializing in nanotechnology. Okay, great. With extensive experience in public health advocacy, research, and project management, she began her career at the Institute of Life Sciences, contributing to targeted cancer therapies. Transitioning into public health, she became a passionate advocate for patient-centric care, focusing on the cardiovascular disease, cancer, mental health, and women's health. Currently, she plays a pivotal role in managing and designing impactful health programs. She is a course advisory committee member for the NIHR Global Health Research Center for Multiple Long-Term Conditions, contributing to practitioner-focused training initiatives like From Knowledge to Action, a practitioner's course to empathetic and meaningful community engagement. As a program manager, at the Patient Academy for Innovation and Research, she works on advancing patients' advocacy and capacity building efforts. Okay, she is a published author, reviewer, and holds certification from prestigious institutions, including Harvard X and Johns Hopkins University. Wow, that's great. So, can Mugdha Barik start her presentation?
Thank you for introducing me, ma'am, and thank you everyone for having me here. I guess I am also one of those people who are a part of the younger population in the room, but it's always a privilege to be, able to contribute in any way possible. Let me share.
You can share your presentation, Mugdha. Yeah.
Yeah, going ahead. Is it visible?
Yes, yes.
All
Make
right.
it full screen, please. Full screen. Yeah.
Oh, sorry. Okay, is it full screen now?
Yes.
All right, wonderful. Okay, so I am one of the authors for the paper Patient Perspectives on Diagnostic Delay and Inadequate Treatment, a qualitative research of endometriosis in India. So, just to give an overview, I mean, in my introduction, the word patient came up a lot, and I do understand that any person in this room has probably heard the word patient more than I have, but I do bring in a unique perspective into this conversation because I speak on behalf of the patients this time around and not, on the receiving end of what the patients are saying. So I work for an organization that sort of deals a lot with patients in the sense that we give a voice to the patient and we advocate for the patients to HCPs, to policy researchers, to the government, etc. So this sort of research has been, based off of that in the sense that I was in a position where I could actually sort of put into words the experiences of people and women living with endometriosis and their experience of sort of navigating through the healthcare system in India and
the reason why I believe this research has been quite instrumental and very well recognized is probably because similar to our previous presenter who brought in a unique perspective, a lot of the times we believe the government has to do something and the institution has to do something, but we as an individual, as an HCP, as a person who's working as a civil society organization can also bring in a lot of value to the patient's lives. So just to catch up on how a biotechnologist ended up speaking for the patient. So I, as we heard, used to work in a lab in Institute of Life Sciences. I used to work in genetic testing for the use of shRNA in cancer cells, oral cancer cells specifically. Now, post-COVID, I transitioned into a public health research mainly because a lot of the work that we were doing had to be halted when COVID happened. And, we realized that a lot of the research that we were doing until now was not necessarily translating into actual value for the people living in the country. Similar to what I think Dr. Radhika mentioned, what you read in the book may not necessarily be what you actually get to implement in the field. So we realized that the research is similar in that sense that, we are publishing a lot of papers, we are doing a lot of research, but it doesn't hold much value when it comes to actual implementation or translation in public health. So that's how I started working in patient advocacy. Now, just to give a brief as to what this study was about, obviously, we worked with women diagnosed with endometriosis. We had a very basic criteria as to what, the women who would be a part of the research. So they had to be 18 plus, based out of India, understood either English or Hindi, so they could, qualitatively participate in the research, and they would consent to being a part of the research as well. So we do not necessarily start off with doing the focus group discussions or anything. The way this entire process started is that we were working extensively with women in PCOS and cervical cancers, and this common trend of women suffering through extensive pain came up. And even though they were having a lot of pain, there was not necessarily any help that they were getting. And we sort of started to look more into it, and we realized that endometriosis is something that is very, very common, like 1 in almost 10 people has it, but it was not something that necessarily came up in our day-to-day lives, even though we deal with thousands of patients on a daily basis and across the disease spectrum. So cancer, mental health, women health, and rare diseases, everything. So we heard more about rare diseases than we did about endometriosis, and it was something that was very sort of perplexing for us, because we couldn't understand why a disease that is so common was not being talked about enough. And we were wondering that if maybe the disease is not as severe, maybe there are a lot of treatment options, maybe enough research has been done, so there's no need. So to understand these things, my team started to do a lot of sort of qualitative research, literature research through several peer-reviewed journals, and we went and talked to a lot of HCPs, and we realized that we were completely wrong, that there is no perfect treatment. The people are in fact in a lot of pain, and there is no sort of sustainable policy for women living with endometriosis. So with this in mind, we realized that there is absolutely no research done for patients or women living with endometriosis in India that would be sort of a comprehensive document that either HCPs or policymakers or even the government could sort of base off of to then adapt to their work or their policy work or any sort of system that they were trying to create. So the irony of the situation was that all the people who were trying to help the patients did not even truly understand what the patients were facing. And I'm not saying this in the sense that the people were ignorant or they were dismissive about the patients. Rather, we as researchers are taught to be so quantitative oriented or number oriented that we do not realize that quality of life for a patient is also something that needs to be researched into, that offering a treatment is not the solution. The treatment actually has to better the life of the person who is seeking the treatment. So that is something, that was the focus of this entire work that we did. So yeah, so as you can see here, we conducted 24 focus group discussions and we came up with 154 participants. We ran a questionnaire through these people, these women, and to understand some of the main things or the struggles that they were going with. And based on these general sort of topics, we created an open-ended questionnaire. And via these focus group discussions, which were mainly more of a like a support group or therapeutic discussions, to be honest, more so than a very structured research. A lot of women came forth and they talked about their experiences from the day they started experiencing the symptom to the actual present day. So we took all of this data, we took all of these over 1,500 minutes of sort of recordings, and we transcribed this, and then we fed this into an analysis tool known as atlas.ti, and we coded this software to work in such a way that it would highlight all the main keywords that were being mentioned over and over and over. So of the 154 participants, there were quite a lot of words or problems or pain points that they kept on mentioning. And these words were flagged by the software. And these words became the emerging themes of our research. So here's a brief, just a BAM overview into what these women found to be problematic, and they really talked about a lot. So in spite of all the gynecologists in this room and all the gynecologists within the country, over 50% women mentioned that they had a delayed diagnosis. And if you go through the paper, you'll see that one of the women had diagnosis of as late as 16 years, and the average was about 9 years. That is a lot. It is a lot for women to go through for a disease that is very common in a country where we have a lot of OB/GYNs. So, we again try to understand why this might be happening, and they came up with quite a lot of reasons as to why this might be happening. So lack of trained lab technicians or medical facilities in rural areas, or core endometriosis specialists, or something as simple as the stigma around pain or periods and stuff like that. So women didn't even know that they needed to go to the hospital because they assumed whatever was happening to them was normal or was something that they should just put up with. A lot of these people sort of blame their mental health or their lifestyle status for what was happening to them, and quite a lot of them because of this were diagnosed in say stage 4 when the endometriosis had inflamed to their lungs and diaphragm and all. So why, again, sort of taking it back to this question of why the study, it is not very detailed as a previous presenter. It is not very usual as to what clinicians and researchers usually do. So why is the study so important? Because it is inspired by patient support groups and real stories. This is not a question of what we as the third person understand from the situation. It is the people receiving the care, navigating through the healthcare system themselves, what they have experienced and what they have to say. So this is real-time evidence from the field level as to what happened. So this is perhaps one of the easiest and most difficult types of research to sort of organize. And the reason why I say this is because it's easy, because there's not a lot of technical, sort of understanding that you need to have into what research is. You may not even necessarily need a lot of resources or financial support to do a research of this kind. But that being said, because you're dealing with a lot of people, there are so many variables. And with research, we understand the more the variables, the more difficult the research is going to be. So something as simple as how do I recognize a woman living with endometriosis? There is no central registry of patients. There is no database that the government has or your hospital has that I can refer to. And even if I do have a database, how do I approach these women? How do I, I can't just call them and be like, okay, I know you're living with endometriosis and I want to do a research, take part in it, because these women have suffered through the system for so long that, they have extreme trust issues and they don't necessarily believe in the system anymore. And I again would like to reiterate, it is not a fault of the HCP or a clinician, and it is neither a fault of the patient. We live in a country that is, very, very imbalanced when it comes to health equity. So it's a problem of the system, and these women, having navigated through this system, did not necessarily trust, the people. So what did this interview teach us? That women really want to be heard. So not just women, patients in general, they really, really do want to be heard. Um, we it is advisable to leverage, patient organizations such as the ones that I worked with to then uh, sort of act as a damp or a shock absorber, if you may, to then approach these patients. Because when a clinician goes and tries to do a research, or even a healthcare policy person such as myself or a researcher goes and tries to do these research, then these patients, they assume that we are doing it from a place of sort of self benefits. It's very selfish, and we are benefiting off of their problems, and they might not necessarily, respond very well to that. So in situations like this, it is very, very important to take an empathetic approach. Um, so the learning curve, obviously, I, being a researcher, started off, with very, very scientific take on it, like use softwares and come up with models and, make charts and all. That did not work out when you're dealing with, women from across the country, having a language barrier, educational, literacy across the spectrum. So we had to take a step back and sort of assess what is it that they were saying, and go back to almost the primitive level of research when we did not have softwares, we did not have principles, we did not have different sort of data graphs and sets and things like that. So went back to the basics and transcribed all the data, listened to it, tried to find any patterns. And then once we had the patterns, then we, again took a step forward from and looked at it from the eyes of a researcher as to what is it that these patterns are telling us. Is it just an inspirational story, something that, an influencer would upload, or is it something that truly speaks for the entire population? So this was truly a learning curve. What we found, these are some of the main observations that we had: delayed diagnosis, normalization of pain, dismissive provider attitudes, inadequate and fragmented treatment, financial burden, and overemphasis on infertility. So again, I want to take a step back to reiterate that this is not a hate speech towards clinicians. This is simply a fault of the system. And these are, a few of the points that I would, maybe a few takeaway points that clinicians, all the people in the room here can maybe adopt in the future to, um, I don't know, I not necessarily change the system, but certainly make it a bit easier for the people to live with, because at the end of the day, a doctor wants the patient to get better. And no matter how difficult the patient may be, if we are not able to give 100% into their treatment, it's not going to work, because the patient is going to come back over and over and over. And in the long run, we are going nowhere. It is just wasteful, and the system is never going to get better. So ask the difficult questions, take an empathetic approach, offer holistic support whenever possible. So counseling, nutritional support, just simple patient support groups, whatever it takes, building patient capacity. So recommending guidebooks, recommending papers, educational videos, things like that, and referring them to the right person. So these are some of the takeaways that we had from the paper. And yeah, that's about it. Thank you for listening to me.
Thank you, Dr. Mugdha, for finishing almost on time, just 1 minute extra. And I really like the way you have done it. Because we have a lot of postgraduate students over here, so can you just explain a little bit how you have conducted the focus group discussion? Just a little bit how you have worked on it. It's not the analysis part, but how do you plan? Because these people, they may not know. You know, we are from gynecological background. We are not these postgraduate students, they are not exposed to qualitative research. So just a few lines, how you have conducted this focus group discussion in this particular group.
So the way we went about it is that we initially identified women who were living with endometriosis. So we did this via, support groups or Facebook groups, social media, leverage different HCPs whom we knew personally. So healthcare professionals who were already working in this field with a lot of endometriotic patients. And once we identified these women, we ran a questionnaire. And these questionnaire, they helped us understand what the women wanted to talk about, what were some of the common pain points that they were not necessarily very happy with addressing. So it helped us as the researchers frame the questions just in the right way that they would be okay or with answering a question. So it's not like we can directly go to them and be like, why did it take so long for you to be diagnosed? You can't do that to a patient, especially someone who has been defeated by the system so many times. So the questionnaire really helped us take a step back and assess all the questions. So it was all so maybe the main takeaway would be in situations like this, when you're dealing with people who have been, suffering through the system, they will not necessarily respond to your questions in a way that you expect them to respond. So as a researcher, we look at everything very clinically or very logically, but logic doesn't apply when emotions come into the picture. So the questionnaire really helped us take this into perspective, into understanding what the people wanted to be asked. And now, based on this questionnaire, we set up 24 focus group discussions. So what focus group discussions are, basically, if it is in person, then it's a closed room conversation. And we did it virtually. So because it was a cross-country discussion. So you invite a bunch of people to the room, in this case, women living with endometriosis, and we created groups of 10 or 20. And we asked questions based on the questionnaire that they had submitted. So this helped us, understand how long did it take for them to be diagnosed, which sort of treatments they went through, what sort of problems they underwent, and something, quite extraordinary, such as one of the patients confided in us that she had undergone surgery, laparoscopic surgery, and she was told that all the, inflamed cells had been removed from her body, only for her to suffer through extreme pain and discomfort a couple of months later. And she dismissed it as, post-surgery recovery. So she struggled through it for a couple of years. And then 2 years later, when it became unbearable to her and she was getting ready to have a child, so she went back for for an inspection. And the HCP that she went to this time around, they realized that the endometriotic cells had never been removed in the first place. This was like a sheer case of medical malpractice, and this is not an information that we would have been able to recover by simple research. We really had to extract this information out of them. So you have to put yourself in a position where you have to talk to them as if you're their friend, and you are trying to give them a voice. You're not supposed to talk as if you just want to publish a paper on them, or you have an ulterior motive out of trying to talk to them. So you have to humanize yourself to that extent. One of the main reasons why I don't go by doctor. So it instantly takes away quite a lot of brownie points when you talk to patients. And you mentioned that you're a doctor, they do not appreciate it. That has been the general consensus. So yeah.
Okay. Thank you so much for explaining that.
I have a query.
And I really like that takeaway message is that the holistic approach is very important, that you have to not the disease, only the infertility somebody pointed out. Okay, thank you very much. Great presentation.
I have a query, ma'am. May I?
Yeah.
Um, uh, most of the focus group discussions which happen in obstetrics, for example, anemia reduction, preeclampsia reduction, have focused on a lot of the partners. Were partners ever involved in these focus group discussions which you held?
No, the focus group discussions were completely with the patient themselves because
Thank you.
this
Thank you.
paper
Thank you.
is
That answers
focused
my
on
question.
patients.
That
Yeah.
answers it. Thank
Dr. Radhika, uh,
Yeah, I think Sunil, we are running short of time. In short, I would say it was a great presentation, Mugdha. And qualitative research has its own challenges. Like you said, it is easy and difficult. It requires some sort of expertise and training. The FDGs and one-to-one, how to capture the data, how to translate that into presentable evidence or presentable formats, and for the audience to be able to absorb the take-home message is, I think, the ultimate thing. So you did well. Thank you very much.
yeah.
Thank you.
Thank you very much, madam. Once again, thanks and congrats, Dr. Mugdha. This tells our young postgraduates regarding methodology and such qualitative studies, especially involving focus group discussions. That is important takeaway. And of course, as far as endometriosis is concerned, it is opening up new questions and the arenas of discussion, which is being like we is having been debates regarding the same thing. It has challenges of normalizing the pain in the society itself. The challenges by the healthcare workers, not only obstetrician, but the role of radiologists are also important. As far as sonography is concerned, even as far as higher modalities like MRI, CT are concerned. And good, your research is going to help the society and the patient group regarding awareness of such important thing in today's era. Once again, thanks a lot. So with the permission of conveners and the experts here, let us go ahead with the further program. And once again, I thank the experts, the chairpersons, and let us go ahead with the further program. The next session is about the introduction and discussion regarding the research tools. And today we are going to discuss, the speaker is Dr. Madhva Prasad regarding the REDCap data tool. I would like to introduce Madhva here. He is my colleague and friend. He is currently working as associate professor at St. John's Medical College, Bangalore. He is part of Jogi team as a dynamic and young national corresponding editor. He is passed out from Mumbai KM Hospital, now faculty at St. John's, also as a part of Nodal Center of NMC, contributor curriculum committee, UG and PG activities, Rajiv Gandhi University of Health Sciences, member committee of confidential inquiries into maternal deaths of Karnataka, and reviewer of medical research studies, BMGF. We welcome you, Madhva.
Thank you.
So you can share your screen and start your presentation.
Yes. Share this. Just a minute. Can you see my screen?
Yeah.
Okay. So thanks for the introduction. So I work with St. John's Medical College Hospital, and a unique thing about my institution is that we have a separate research institute. So I am in turn going to introduce Dr. Ryan Fernandez, who is a faculty in medical informatics. He's specialized in electronic medical records and has a vast experience in HIS implementation. He's the REDCap go-to person for SGRI. So when I was invited to speak about REDCap, I thought I would in turn invite the best person to speak about REDCap. He will speak initially and then take things forward. Ryan, over to you.
Hi, good evening, madam. Good evening, sir. So I am Dr. Ryan Fernandez.
Madhav, you want to briefly introduce Dr. Ryan? You want me to introduce Dr. Ryan? Okay, briefly I'll introduce. Dr. Ryan, we welcome you. He is faculty at Medical Informatics, St. John's Research Institute, and he is basically a dental surgeon by training, but joined the Medical Informatics in 2003 division of SJRI, that is St. John's Research Institute, specialized in creating EB health information for EMR. He has got vast experience in implementing HIS, systems. Further, he has masters in business law, IPR, contract law, etc. And he is, as Madhva said, he is a red cap go-to person at SJR. Thank you for contributing, and please, both of you can go ahead with your presentations. Thank you.
Can I share my screen? I'll just
Please.
Yeah. So I hope you can see my screen for now. Yeah.
Yeah, we can. You can make it full screen and go ahead.
Yes. So I'm Dr. Ryan Fernandez. I'm an assistant professor at the Division of Medical Informatics at St. John's Research Institute. So we take care of this REDCap, okay, Research Electronic Data Capture. And basically REDCap is a system where we collect research data through either surveys or online forms. So these are some of the means that we actually collect using a browser or using an app or even on paper. For example, if any of the online means is not there, we can always fall back by taking a print on paper and using that particular PDF for that particular study. Okay. And there are two types of forms in REDCap. One is a survey and the other is a form wherein the field worker has to log in and then collect data on the online form. Okay. So this is how REDCap actually presents itself. So it is there across 2000 consortium members or universities, you can say, or even organizations for that matter, across 100 countries in the world. Okay, so we have a good number of institutions in India which actually use REDCap and to some extent collect data on the field and use it for their particular research studies. Yeah. So yeah, so it is accessible across various devices. If you see, it doesn't matter which device you actually use, whether it's a tablet or a laptop or even a mobile phone, any kind of device, whether it's a system, Apple or even Windows, REDCap is accessible across any system and across all devices. So that doesn't matter. Just from a browser in a laptop, I can actually access REDCap. So this is how the processes of actually building the forms. Okay, so initially what we do is we meet the PI and we ask what are the forms, what is your requirement and what type of forms you want. Okay, so we collect that particular forms and then we build that or we code it on REDCap. Okay, so that's the first step. Then we actually also build workflows. For example, in a clinical trial, you may have two arms. You may have a control arm, you may have a experimental arm. So each arms will have different types of visits. The follow-up would be different. At different points of time, different forms would be administered to that particular subject. So we can still configure two arms or three arms, whatever is required as per the study protocol. So once we actually finalize the workflows and the events, then we release it after some testing to the field workers. So then the field workers actually go about collecting data and making sure that all the visits are followed up. So once the data is actually collected, okay, the next step would be to actually that the PI sits with the statistician and validates the data, make sure that the data is cleaned properly. Any kind of if there is any mistakes or errors noticed, that particular data or those particular fields are deleted or they are cleaned off. And then that data may be analyzed for your particular research or for your particular publication, or it may be a conference presentation. And for some period of time, you can store your data on Excel or even on REDCap. We can archive the data. So in general, if you look at this step, this particular slide summarizes all the processes, research processes that we do on REDCap. Okay. So now looking at the features of REDCap, okay. So there are different types of fields that we have, okay. Like one could be just a text field where we enter data, okay. Like we could enter any text value or whatever it is. Second is a drop down. You might have seen a drop down, like what are the states in India or what is the gender? It could be male, female, or other, okay. So that is a drop down. A radio button is similar to a drop down. Only thing is the user can see all the variables or what are the options available. So in that way, in the field, it is much better because the user knows, okay, I have only three options. I can select A, B, or C. Okay, if it is a bigger, like there are more number of options, then we prefer to have it as a drop down. Then we have something called as a checklist. For example, we could ask a patient, what are your symptoms? Okay, so it could be pain, swelling, or any other symptom. So from the checklist, the particular user can select, okay, there is pain, there is swelling, there is so another symptom, and maybe even like you could have to capture other, wherein other could be recoded, and you can have a text box there and you could put in whatever text you want. Okay, so these are some of the things like checklist, text box, paragraph box. Okay, like if you want to collect some qualitative data, okay, like in the form of a story or some kind of history, which is there is text, you can always have a paragraph text box. Also with that, you can have a character limit or a word limit. So in that way, the user is restricted to entering maybe 300 words or whatever you feel like. You can even have a rating scale where you can capture ratings like pain ratings or whatever it is. There is something also called as a matrix of field. You might have seen a Likert scale from unsatisfied, completely unsatisfied to completely satisfied. All the options you can have in one kind of a matrix set. Okay. Also, there is scheduling and there is event. So you can have different schedules. You can put your events, and as per the event, your users will be alerted to fill up so and so form. So each field for that matter, you can actually validate it. You can ensure that date is collected, even minute, second, all that is collected. You may have a field for email. So that way also your email is captured in that exact format. So in this way, the error is much lesser by having a validation. Yeah, so there is something called as a dashboard in RedCap, wherein the PI can just log in and see and understand. If you look at this particular screen, I know that there is patient 1, 2, 3. You have a patient subject name and maybe a date of birth. Then you have these forms, demographics, randomization. Beyond that, so many forms. So I know that when there is a red dot, it means that the form is incomplete. You have the legends on the right-hand side. When there is a green form, it means that the form is completed and validated. And when there is a yellow form, it means that it is unverified. So maybe in this instance, the PI has to log in and view the data and validate it and say that the data is completed in this particular form. Yeah, so not only this, RedCap also supports RCTs, randomized controlled trials, wherein subjects can be put in different groups or in different sets. Okay, so you can assign a patient to a particular set. That is done by the system itself. Okay, it could be from a randomization table, which is in the back end of RedCap, given by the statistician. Okay, so you collect that particular randomization table, we insert it in the backend of RedCap. It is completely blind. We can block it from the PI or the co-PI. We can provide access only to the statistician to this backend information. And in this way, your trials are completely secure and you have complete, you're meeting the protocol of randomization. You can also assign patients, like you can, instead of having a table, you can assign every third patient to this particular group or every fifth patient to a particular group. So that way, different forms of randomization, different designs of randomization, you can facilitate using RedCap. And also, like once you collect your data, PIs are interested in how the data looks like, okay, whether, so one way of actually looking at it is through reports. So I can capture all my, whatever fields I want, I can make sure that these fields can be seen in one screen. And I can also put a qualifying factor or a filter saying that maybe I want to see whatever patients meet so and so, like if patients above the, between the age of 18 to 25, I want to look at this patients and I want to see where they are stay, what is their email address or what is their phone number. So that way also I can see it and I can also download my data. So one good thing about RedCap is once I download my data, I can actually put it on a statistical software like SAS, SPSS, or R, and I can, it will process it in whatever way you would like to see it. And then you can derive pie charts or whatever statistics you want, you can derive it. So as I was saying, you can download your data in different formats. CSV is the usual industrial standard that we follow, .csv, but there are others like SPSS, SAS, R. So once you, like say for example, if I download it in Stata format, it will give me one file containing the data and the other file containing the data dictionary, meaning what each field is, telling the SAS data software that this field represents this particular variable. So this is a good thing that REDCap actually has. You can use any particular statistical software and analyze your data, slice your data, dice your data, whatever it is. So in that way, REDCap supports whatever research studies and whatever analysis you require, it can undertake. So this is some example of what you actually see. Every variable on REDCap, you will get a statistics like this. What type of pain or what is the missing values, all that you get to know. So other than actually viewing it on in a tablet or in a laptop, you can actually work offline REDCap also. I can take it to the field. I can send my users to an area where there's no internet. Okay, so in that way, morning is when the field workers go out, they are maybe at the site, they can download the data, go to the field, collect the data completely offline, come back in the evening, and then upload the data to the server. So in that way, like you can also ensure that remote sites are have access to like entering data on REDCap. So as I told you, there are a lot of benefits. We can customize, we can do randomized. We can also like import data. Like say if I have a set of data of some patient which was retrospectively collected, I can still import that into REDCap. I can even do double data entry. So there are some studies that actually require to have two data entry operators, that two data people collect the data. So that also is something which is facilitated by REDCap. There is double data entry option. Yeah, so that's all I have, sir. But I hope this was useful to all of you.
Yes, thanks a lot, Dr. Ryan, for providing this introduction.
Sure.
So now the aspects and benefits are already discussed. Now I'll
Sure.
quickly show the live demonstration.
Sure.
Can you all see my screen now?
Yeah, 1 second. I'll just stop sharing. I've done it. Yeah, we can see your screen.
Okay. So
So while you are doing that, Madhav, yeah. So if you're starting, it's fine. Yeah.
yes. Yes. So basically, what happens is most of us researchers, we have these challenges. Time is short, systems need to be efficient, different study designs need different formats. So many items are repetitive, designing the Excel sheet for every study, pro forma of data collection for every study. Many a times, you complete the entire study and then you realize that there is missing data. Data stayed at multiple locations. There is supervision issues, like, a junior collects the data and the senior is not able to see it. These are the main issues. All of them are solved by the REDCap, right? So basically, as a researcher myself, I have been using REDCap very recently. So it has a very intuitive interface. Like, once you get just a minute. Yeah. So once you get a login option, this is where we start. And I say new project. When I say new project, it allows me to start a title. It asks for a purpose, and then it asks me create an empty project. You can do, start de novo, or you can use a template. So the most important thing is that there is a template available. So what happens is, say for example, I was just working on some cardiac marker in preeclampsia. So this is what it looks like. It's very intuitive. The title, the purpose, what kind of type of study, etc. Now, as you move forward, you can see here. If I say, there are these inbuilt study designs with customizable options. So you can say, I'm using a template, basic demography, classic database, human cancer tissue bank, longitudinal database. Multiple surveys, longitudinal surveys, RCTs. So you can see that your entire burden of creating those multiple Excel sheets is all gone with this. You just have to choose one particular methodology and it will auto direct you towards a particular format, right? So then At all steps, your data is secure because you can see, like, even before I could enter anything, it'll ask you a security question and your data is secure. That's another feature. Data entry. So first, when you start planning for the project, you can begin with the end in mind. So for example, here you can see in a project, there is something called project setup. Here, main project settings, design your data collection improvements and define your events. So you can actually design exactly, you can envision what you are going to do using this red cap. So so this is one thing. So then the common headings under which we collect data are demographics and specific details. So what is there here is, once you go into the demographics, it's already some inbuilt features. So this is a screenshot of the inbuilt features. So in case you want to delete something, suppose you're not going to take the contact information, you can just delete it. So like, for example, you're not going to take the name, you can delete it. Or you want to add something, you can just say add field and that gets added. So all these things are inbuilt features. Then common details, like for example, is the patient on any medication? What is the some inbuilt functions are there which can be utilized or deleted. Then common things like height, weight, BMI. Sometimes we tend to forget including.
Can I ask you a question, Madhav,
Yes,
here?
yes,
Dr. Shobha Guri here.
Yes,
If you are saying that there is inbuilt information, is there
yes.
a drop-down service where you get some options, or
yes, ma'am. That is
can you ask it in somewhere, or?
Yes, ma'am. The drop-down services are coming later, ma'am. So what happens is, this is in the demographics. So here we have the patient's BMI, we just enter it here. If we height, we just enter it here. So these are all not in a drop-down.
Okay. You said na ki there is more can be added. So I thought whether more options will come up here only.
Yes.
Like for example, race and ethnicity, whether that will come.
Coming.
That, I thought.
Doctor, like if you can share the previous screen. Okay, this BMI is fine. BMI, just the BMI part.
Okay.
So say for example here, BMI is a calculated field. So when you enter the height and when you enter the weight, it picks up the formula in the back end and it gives the BMI. So that kind of validation is also there in RedCap.
Yeah, that is what I wanted. Extra because all these things kuch hai na yahan pe. One is a pen, one is some copy, one is something. So features, so many features are seen here. So I thought I'll ask. Okay.
I'll continue, ma'am. Yeah. So yes. So then. So then, again, there are some pre-filled details which you can keep or delete. So now, in case we want to add something, like for example, so these in the drop-down menu, there are a lot of things like, it can be a short text, it can be a number, it can be a date or time, etc. And moving forward, so suppose I want the NT-pro BNP value. So here I am adding this and I am saying this as it is a required field, because without this particular value, the study will not move forward. So what is happening is, it ensures that the study, is the data collection is foolproof once you make it a required field. Then, like for example, a common difficulty that we face with Excel sheets are the dates are written as numbers. Sometimes you make it 25 and it will change the format. So all that format gets fixed. So here, this is again a drop-down menu where you can choose what kind of format in which the number gets entered. Then laboratory data, we can say as a multiple choice. In this, so suppose my study is analyzing correlation of a cardiac marker with preeclampsia. All I did in the multiple, I have not shown that particular slide. All I did in the multiple choice was no preeclampsia, mild preeclampsia, severe preeclampsia. The moment, sorry for exceeding time. So the moment we write those three, options, immediately this comes up. So it automatically codes. So moving forward, this is what I entered and it got coded. Now, like this, again, urine albumin. I wrote these entries, it got coded. So I'll move on forward. So now I have removed all those things which are unnecessary to my study and I have kept only these values. And say, for example, I'm looking at delivery outcomes also. Again, I'm looking at the date of delivery and I'm looking at the same format in which it is supposed to come, right? Then then I'm looking at, mode of delivery. Again, similarly, it got coded. So what happens is there is a good code book which gets generated automatically without much difficulty. This is something which is very important for the researcher who is handling large data. Then the actual data entry, right? So in the data entry, it gets nicely, what we use in Excel sheet is, we use sheet 1, sheet 2, sheet 3. That gets obviated here in terms of demographics, baseline, visit, lab data, etc. Right? Now, again, this will depend on the type of study that you have already. If it is a longitudinal, it will give you multiple time points. So, okay, so this is the actual data entry. It allows you to add name and details, whatever demographics you had actually chosen. Now, the most important thing is this. It asks you a question, is it complete or not complete? If it is indeed complete, then it will show you a green button. And if it is not complete, it shows you a red button. So what happens, you can see here. So in the enrollment is all the data complete. In the visit one is all the data complete. In case it is not, you know that there is pending work, right? So this is a very important aspect of REDCap, right? So again, this is further moving on. So now, for example, I have come to the end of data entry and I can now move on to some analysis. So now what happens is, now focus here, I can see here that there is, I can change some options also if necessary, make editing if at all there is necessary. And here I have a comprehensive view of which all patients' data is missing. Then move here. You can see here data, exports, reports, and statistics. Once I click on that, automatically I choose which data I want analyzed and I get my results. This is what in the prior presentation, some results were already given. Now I can see here, refresh plot. Now, right now it is showing in this kind of a, if I suppose I want something else, I'm viewing as a bar chart. Suppose I want to view as a pie. I just have to put it to the drop down and it automatically gets converted to a whichever mode I wanted to see. So the analysis is also kind of inbuilt within this system. So that's not all. There are so many more features. Like for example, every for the purpose of this presentation in the morning, I was making some changes. You're able to see that some changes were made. Now this is where the regulatory help. Now suppose it's a shared document and a student is making a change. The senior is able to see that some changes were done. It obviates the thing of, oh, I have done the data entry, but it is not showing. Those kind of things are avoided. Not just that. For example, you can maintain data quality. Like for example, blank values, validation errors, hidden fields, all these things get taken care of. Once you define what the problem is, you will be able to extract errors also. For example, outliers. Suppose a value, blood pressure, 120 by 80, 120 by 80. Suppose by chance somebody has entered 1200, just one extra zero. Those kind of outliers, those kind of mistakes which changes the entire values can be avoided, right? So there is we don't have much time to demonstrate all its features, but I encourage each of the viewer to go to the REDCap website and look at the the videos where there is a lot of deep dive into this. So yeah, so just to summarize, the entire journey from data collection to final results can be held in one platform. There's an inbuilt system which provides checks and balances, quality checks, easy shareability, and it can provide instant statistical results to in a method that is acceptable to everyone. Yes. Overall, there is a smoothing of data handling. Thank you. That's the end of my speech.
Thank you, Dr. Madhav, Dr. Ryan.
Sunil, one thing was not clear to me, Sunil,
Hmm.
is when he was showing data entry. So I enter one data and then I take up the next patient and then you generate again the fresh page and you enter the second patient.
There is an option called add entry, ma'am. So
Add
it's
entry. So you go to that.
plus mark with a green
So
is there
suppose,
usually. Yeah. So
ठीक है,
it's
ठीक है.
all the
So
data.
suppose I take 50 cases I take, okay, for any particular study. So it is all there in one place, right? The 50 cases. And
Yes.
then this is only data collection, or this tool gives us some kind of way forward for statistical analysis, conclusions and all that inbuilt. So is there some kind of master chart also which is generated?
Yes, ma'am. It can be extracted into a CSV format or an Excel format. Like I think.
So, but then will it guide us, Madhav, as to for that particular study what kind of sample is it enough or not, or whether you know, or whether it is
Ryan, does it
whether
calculate a sample size?
Yeah, so madam, our sample, of course, we have a separate software like I think they
अच्छा,
use
तो वो that is
the
all pre-designed and then you
yeah
can start the study.
yeah
That's what
but
you want.
yeah
But
so
ये
but
इसमें will it guide us as to what statistical tool to use, because
uh,
clinicians are all very poor
yeah
in this, no?
yeah.
So
So
we
madam,
need to.
simple thing, statistics and all, RedCap is able to calculate mean, all
हाँ,
that, what are the extreme values,
p
all
value, p.
So
standard deviation, all that
हाँ,
variable by variable you'll get in
अच्छा,
RedCap
okay.
itself.
अच्छा, okay,
it
okay.
is
Does this cost us, this application? This.
So, ma'am, RedCap is open source in the sense that the Vanderbilt University actually gives it to other institutions across any part of the world. So, I think there is a form online that we need to fill up. Once we fill up the form, then RedCap will send you the link to download the code for having in your institution. So, madam, it's free till this point, and it's open source in the sense that we can install it on our system in the institute, and you can do your research studies purely for research. It is not preferred for services or any kind of hospital care because that data is huge, but for a research study we can use it in our.
So how much data will it support? How many patient data? It will support up to 100 or
Okay.
up to
So, madam, from
500,000?
yeah, so from my experience, I can tell you, madam, we had done one very large study with calcium in pregnant women, and we had involved right from visit week 6 to 40th week almost, like for pregnant women, and then we went also postnatal, post after delivery also. So we collected about the N was 10,000, but to get that 10,000, we needed 35,000 women, pregnant women, because that was the screening rate, because there were more of ineligibles also. So finally, we were after collecting 35,000, we were able to get that 10,000 in for that study. But RedCap is able to support for these 10,000, it was able to support multiple visits. So that is all feasible, madam, in RedCap. Sure.
Amazing, actually. Very good technology. Thank you
So,
so much.
the
Yeah.
question is,
Thank you.
Choka, in response to your question, hello, am I
Yes,
audible?
yes, ma'am, you
yes.
are audible.
Yeah, I'm listening. I'm listening. Yeah.
It's raining heavily in Delhi, so this is
Yeah,
low.
Radhika, it's raining in Bangalore also,
Oh,
but not very heavy.
okay. So I
Yeah.
just wanted to say that today the Excel sheet has majority of the inbuilt systems which are required for simple calculations, for an observational study.
Yes.
Because like it has already been highlighted that RedCap is available for institutions and not, it's not for individual subscription. Number
Yes.
one.
Mm.
But the biggest advantage with RedCap is, those things which have already been spoken about, especially the large sample size, large multiple entries, multi-site data, even duplicates can be done. So those sort of things. But for the young researchers who are starting their research, should not be put off with this kind of software. This is to make people aware that such things are today available for to us to
Sure.
facilitate the data management, because typically what happens is you end up getting a large volume data and end up not knowing what to do. You suddenly are depending on the statistics department who would be otherwise multitasking also. So
Sure.
I would encourage everybody to please work on the Excel sheet, get the basics right, and now you also have something called the pivot table analysis. It's even available on the Drive. You use the Google Drive and use the Excel documents in the Doc Hub. in the Google, it also has many features, including creating graphs.
Sure.
So, I would also want people to look at the Excel sheet, the basic one, and then also be familiar with RedCap kind of good softwares. So that was basically I didn't want people to feel diffident, with these softwares
Yeah.
also. That was the
Yeah.
reason.
Yeah. So,
Thank you.
How
madam,
to
what you
apply for
told,
the institution, Dr. Radhika? How to apply for the institution? Dr.
So,
Rian, you can tell.
Shashwat,
How to apply for the institution?
sure.
yeah, so you could go to the website, the Red Cap.
Sure.
Okay.
There is a registration, there is a site for registration. There is a form to be filled and formality to be done. It is fairly easy.
Sure.
And
Okay.
lot of
Okay.
tutorials are available, and it is generally the interface is user friendly and easy to use.
Sure.
But
Okay.
like
Okay.
let us not straight away go to the red cap thing. It is basically for the mid career people, because I was expecting people from the ones who are interested in research going on to bigger, large level of data. So
Sure.
people have to be aware of what is available. So that was the idea of this presentation, please.
Yeah.
Sure.
Yeah. Actually, I'm asking because I work in the medical research unit of our medical
Yeah,
college.
yeah,
So
I'm
that
aware.
is why I'm asking. Yeah.
Yeah, certainly. So the big institutions should really go for it because they are the
Hmm.
ones who are churning out large quality research and large volume research in terms of sample
Yes.
size.
Okay.
Yeah.
Thank
So,
you. Thank you so
Dr.
much.
Radhika, you are absolutely correct in saying that basics should be with Excel. Okay, that is absolutely true because in RedCap, most of the coding, whatever the coding we do, is all Excel derived. Whatever coding we are able to do, if somebody is able to work on Excel, definitely they can use the Excel codes to use it for RedCap. So that is a good thing, madam, that you have told.
Yeah. Thanks for agreeing on that.
Yeah.
Okay, thank you very much,
Sure.
Dr. Madhwa, Dr. Ryan, and all the faculty.
Thank you, sir.
We are finishing on time. So I would like to request today's coordinator for the program, Dr. Pradnya Madam, to go ahead with the vote of thanks.
Pradnya, we can't hear you.
Pradnya
But
Madam, are
is
you there?
not there. I think Sunil, you can give vote of thanks.
No, we
Actually, I
could
missed
see
I
Pradnya.
missed being there in the beginning. So please humor me. I must greet Dr. Parag Biniwale and I must meet Dr. Sujata Dalvi. Good evening, both of you.
Hello.
And as well as others also. Pragna, hi. And
Hello, ma'am.
Shashwati, hi, dear.
Dr. Parag sir and Sujata Madam, if any inputs from your side, please go ahead.
No, it went on very well. And lots of input so far as search engine
Fine.
is concerned. Of course, Dr.
It
Madhava
was,
has
it was definitely
Both
interesting.
interesting. It's
everything.
very, very interesting. Only
Yes,
thing is,
it was
when we listen to it, we are so thrilled. But then we don't know what to do with all that.
correct.
It is so difficult to
Shobha, for you,
perform
it's easy.
research.
You just have to call Madhava and Ryan.
I will do that.
Uh,
I'll
You
do
get
that.
to
Madhav,
that.
I'll speak on behalf of Ryan Fernandez, sir, that
Hmm.
SJRA will be happy to hold an implementing statistics program.
Sorry,
Can you
Shobha Madam and
take
Madhva, I would
statistics
like to
program,
tell some.
Madhava?
the
Madhava,
Thank you.
are you
Thank
willing
you.
to take statistics program?
Yes, definitely. I'm sure the Dean of SJRI will be actually in SJRI, we are conducting regular research methodology programs. Like Radhika ma'am said, it is not for the absolute basic postgraduate students. It's a little higher level where, and in fact, there is a twice a year one week program which is conducted. I think it is in association with Ryan. It's with University of the Canadian University. I'm not
Yes,
sure.
yes, yes. I think McGill University has it every year. It's
Yeah.
like conducted by the Division of Clinical Research and Training. So they have about one or two programs every year, and faculty from abroad come and take you to the entire thing of research methodology, all the aspects are covered. And at the end of the day, everyone gets a chance to present about their research protocol, how they would like to go about with their research.
Hmm.
Sunil.
Yeah, Shobha madam and Madhva, I would like to reiterate this. I mean, I have experienced this because my thesis was under Dr. Shobha madam in
Correct.
Bangalore in St. Philomena's Hospital.
You published also, no, man?
Yes, ma'am. And
Yeah.
then I had to take help from statisticians at St. John's Medical College.
Oh, yes.
Yeah.
So I have visited multiple times there and it was quite helpful.
Yes, even we resort to St. John's, and now Madhva is also in St. John's. So it is
And
good.
Dr. Ryan, we will be interested if at all online programs are there.
Definitely,
Sure,
definitely.
sure.
Yes.
We can explore that, Doctor.
Mm, mm.
Dr.
you.
Parag, with your permission, can I say something? Because Dr.
Yes,
Sujata
please.
Darji is there. Yeah, this is a very personal because it is a Jogi. That is why, because I'm not getting my journal for last one whole year. I have written
My
to the
God.
office, but I don't know what has happened. Even I had two of my this thing is published when Geeta was there, but still now I'm not been able to get my journal. So I don't
I'll
know how
figure out
to
with
handle
Maria.
this.
I'll figure out with Maria why you're not getting it. Just now we wrote one letter to one more society where they had the clerical staff over there had written the same pin code number for all 100 members. That's why the journal was not reaching. So, like, we'll just try and figure out
I'm a
and we'll
very
get
old
back to you.
member actually. I'm 66 years old.
No
So
problem. I'll just figure
I
out with
used to
Maria.
get a long
I'm
time
in
to
the
come, so I
office.
don't know what has happened.
So
I'm in
sweet.
the office. Just give me 2 minutes and I'll figure out with her.
That is so
Okay,
sweet
okay.
of you,
Thank you so
Shashwati.
much. Yeah, because if you don't get it, then you feel so bad. And my own paper was there, so I was not getting it.
Definitely, definitely.
So I'm not a
Sunil कुछ
new
बोल
member
रहा था
that
No,
तभी.
no. Ma'am,
this will not be the
I'll
kind of thing.
help
Okay,
Sujata
thank you
madam
so
to
much.
look into
Sorry.
it. Yeah.
Yeah, Sunil is also there. You can also help me out, I believe.
Yes, ma'am. We would
Dr.
like to help you.
Shashwati, sorry, Maria said to send an email that you're not receiving the journal and we'll do the needful for you.
To you, Sujata?
Yeah, you just send an email to journal
Okay,
OBGYN
sure.
Ma'am,
at
I'll message
gmail.com
you the
and
mail ID. I'll
we'll look
message you.
into it. We'll look
I'll
into it. We are in the office.
Okay, thank you so much.
I'll
Thank
message
you.
you, ma'am. Yeah.
So we had excellent speakers today, Dr. Ayesha, Dr. Mugda, Dr. Madhva, Dr. Ryan, and this was a program which was jointly conducted by Foxy, ICOG and Jogi. And we thank the conveners, Dr. Sujata Darvi ma'am, Dr. A.G. Radhika ma'am, for planning this very well. We thank the MOC, Dr. Sunil Tambekar, for executing this well. And all this is with the blessings of Foxy and ICOG, eminent faculties, Dr. Sunita Tandulwadkar ma'am, who is the President Foxy, Dr. Suvarna Khadilkar ma'am, Secretary General Foxy, Dr. Parag Binewale sir, who is the head of the ICOG. We have Secretary ICOG, Dr. Sarita Bhalerao ma'am, and of course the editor-in-chief of Jogi, Dr. Sujata Darvi ma'am. So thank you everyone. We had an excellent audience and speaker interaction also. So thank you everyone for your patient listening, and we'll have the program next month also on the second Tuesday.
Thank you.
And we'll declare it soon. Thank you so much.
Thank you. Thanks a lot. Bye.
Thank you. Very nice.
Thank you. Bye-bye.
Thank you, Pradnya. Thank you, everybody.
Thank you, ma'am.
Bye.